Hello, everyone, and welcome. I am Sue McCann, Services Manager at the Foundation. Thank you for joining our Answers from the Experts Q&A program. We are very excited to have you here. Before I introduce our expert presenters, I'd like to go over some housekeeping details. You have joined us for the Q&A to be able to ask your questions of these experts. To do this, there is a tool in Zoom where you can enter your questions, so be sure to use this tool rather than the chat feature to enter your questions throughout the program. We are recording this, and it will be available in a few days on the Foundation's YouTube channel. We would also like to thank our individual donors and our funding partners for making this program possible. We cannot do it without their support. This is how we're able to produce patient education forums, webinars, publications, and other educational programs. So thank you for your donations. Finally, upon conclusion of the webinar, there will be a survey that pops up on your screen as you exit. We would appreciate you taking the time to complete this survey. Now, it is my pleasure to share some information on our speakers for today. Today we have Dr. Amy Musiek and Dr. Neha Mehta-Shah. Dr. Musiek is a board-certified professor of medicine at Washington University, St. Louis, Missouri, in the dermatology division, affiliated with the Institute of Clinical and Translational Sciences, the Siteman Cancer Center, Barnes Jewish Hospital, and St. Louis Children's Hospital. She received her medical degree and residency training from Vanderbilt University School of Medicine and Medical Center, and her fellowship training in cutaneous lymphoma and clinical trials at the University of Pennsylvania in Philadelphia. She has been practicing for more than 20 years. Dr. Musiek has expertise in general medical dermatology, cutaneous lymphoma, autoimmune skin disease, and dermatologic therapeutics. Now, on to Dr. Mehta-Shah. She is an associate professor of medicine at Washington University in St. Louis, where she specializes in T-cell lymphomas. She completed her residency and fellowship at New York Presbyterian Weill Cornell Medical Center and Memorial Sloan Kettering, respectively. She also holds a Master of Science in Clinical Investigations from WashU. She has been recognized with multiple career development awards from organizations such as the American Society of Hematology and the Lymphoma Research Foundation, among others. Dr. Mehta-Shah currently leads multiple clinical trials in T-cell lymphoma, sits on multiple national scientific panels and committees while presenting at conferences in the U.S. and internationally. With those introductions, let's go ahead and get started and welcome Dr. Musiek and Dr. Mehta-Shah. Thank you so much for joining us today. Welcome, Dr. Musiek.
Thank you for having me.
Great. And welcome, Dr. Mehta-Shah.
Yeah, our pleasure to be here today.
Yes, and it's our pleasure to have both of you. So before we go to our first question, as a reminder, Drs. Musiek and Mehta-Shah are here offering their opinions and answers to your questions based on their experience and knowledge in the specialty of cutaneous lymphoma and through their experiences with their own patients. These are not second opinions, and any specific questions that you have should always be asked of your own medical providers. With that, we are ready for our first question. So this is a big one. What are the new drugs for Sezary syndrome? Are they in trials now?
I can start with some of that. So there are multiple drugs and classes of agents in investigation for cutaneous lymphoma and specifically for Sezary syndrome. Some of these are agents looking at combinations of therapy of existing drugs like histone deacetylase inhibitors. There are also ongoing studies of a anti-KIR-DL2 antibody therapy called lacutamab, which finished its phase 2 studies and which has been presented with hopes for a phase 3 study in the upcoming future. And that specifically is being developed for Sezary syndrome, where most patients with Sezary do express that KIR-DL2 protein on their cancer cells. Additionally, there are studies of looking at drugs called EZH2 inhibitors, which have gained a lot of excitement in the peripheral T-cell lymphoma field. And those studies are open here at WashU, but then also open elsewhere in the country. And lastly, I would say that there are efforts to look at bispecific antibodies or immunotherapy type of treatments those studies are just beginning and open at some places across the country, looking specifically at Sezary syndrome And similarly, looking at things called CAR T cells or cellular therapy, where you engineer your own immune cells to kill the lymphoma cells. And those studies are also ongoing, looking at cutaneous lymphomas, including Sezary syndrome.
Wow. Well, that's a lot to digest. A lot of great information there. Thank you. Okay, next one. I suspect that the patches on my inner thighs are there because those areas never get any light, even in the summer. Are there available medical grade narrowband UVB devices for home use that are available in the UK? And what are the risks of skin cancer using narrowband UVB? I understand it's pretty low, but is that correct? Thank you. Dr. Musiek?
Yeah, absolutely. So I have to admit, I'm not familiar with the UK. We do have several handheld devices available in this country. Specifically, a lot of our patients use the devices that are made for the scalp, so that looks sort of like brushes, but they use them as handheld devices for areas on the skin. There are several companies here in the US that make those devices. A lot of our data on skin cancer risk and narrowband UVB therapy comes from our psoriasis population. So we know in our psoriasis population that if there is a risk of skin cancer with narrowband UVB, it is like not detectable or barely detectable. So traditionally, we do not worry about our patients that are getting narrowband UVB developing multiple skin cancers. And I feel comfortable using narrowband UVB in patients that have skin cancers in the past. That being said, a lot of times we'll choose to shield things, meaning cover them. Places like the face that get a lot of sun exposure anyway, we'll choose to cover those while the patient's getting phototherapy.
Thank you. So another one on phototherapy. It's working to clear some spots, but new patches keep occurring. Is it reasonable to combine methotrexate with narrowband UVB?
So while it is absolutely reasonable to combine the two, it needs to be done by someone experienced in doing that. So methotrexate is a photosensitizer, even at low doses. So if you're on light therapy and you add methotrexate, you would want to start your light therapy dose over at the lowest possible dose. And then if you're new and you're going to combine both of them, we would want our phototherapy treatment to start at the lowest possible dose and increase very gradually to ensure you don't burn. There are patients that won't be able to tolerate the combination, but if you start at a low level and increase very slowly, then most people can be successful doing that.
Great. Well, that's encouraging. Thanks. Okay, what type of chemo is best for T-cell lymphoma? Why does the skin look like a burn victim's skin? Do you want to start, Dr. Mehta-Shah?
I can start with the first part of that question. I don't think there's one single chemotherapy that is best for T-cell lymphomas. There are multiple, in cutaneous T-cell lymphoma, we sometimes use what we call single agent sequential chemotherapy. So unlike other lymphomas where we often combine multiple chemotherapies at the same time, we often use one treatment at a time. And that's partly because the goals of treatment in cutaneous lymphoma are different. The goal is to continue on the treatment and maintain a patient's quality of life and improve their quality of life related to their cancer, and then also not burden them with impairments in quality of life related to the treatment. So there are multiple chemotherapy medicines that are used for cutaneous lymphoma. These are like traditional chemotherapy drugs that injure the process of one cell dividing into two by attacking their DNA replication process. And those include liposomal doxorubicin or gemcitabine, are commonly used chemotherapeutic agents used in CTCL. Similarly, oral chemotherapy, like drugs like methotrexate, are also used to treat CTCL. And really picking the agent is based on the burden of disease and where that disease is. We know some drugs work a little bit better on the skin, and some drugs work a little bit better in the bloodstream, and some drugs work a little bit better for lymph nodes. And that's a good discussion to have with your doctor.
Okay, Dr. Musiek, how about that burn skin look?
Yeah, so when you have Sezary syndrome or other forms of cutaneous T-cell lymphoma, you have lots of the immune system cells, lymphocytes, sort of infiltrating the skin. That causes two things to happen. That causes the skin to turn over quickly, which is why you get that sort of constant scaling that we see in our patients with mycosis fungoides or Sezary syndrome. And it also causes a lot of that redness. So the best solution for getting the skin to look better is to treat the underlying lymphoma. And then some of those problems that the lymphocytes or the immune system cells are triggering will correct themselves.
Great, thank you both. So I was diagnosed with CTCL in 2021 at age 78. Treatment is currently continuing as 3 times a week light therapy plus clobetasol as needed for brighter spots that occur. At the continuing stage of MF1A, what is the expectation of probability of progression, and are any treatment options that could lead to total remission?
So there are some treatment options that could lead to total remission, but those would require super intense therapy, something like a stem cell transplant, which we would not do in our stage 1A patients. And the reason we wouldn't do those is the risk of progression is so low. Less than 20% of patients ever progress to later stage disease. And if that progression is going to happen, it typically happens within the first 2 years. So we like to pick treatments that are very safe for patients to stay on for a very long period of time. The goal is to make your skin feel and look more comfortable to you, but not cause long-term side effects with the treatment. So narrowband with clobetasol is a great choice for stage 1A disease, and it's okay for spots to come and go. We like to see more spots go than come, but we're happy, when you're happy with how your skin looks and feels, and we're happy with a little bit of disease on the skin, as long as it is mostly doing better than it was when you started treatment, and that most of the spots are going and not coming.
Great. That provides a lot of good direction. What stage does or should treatment start? So this is a very general one. You can both take a stab at it if you'd like.
I think as Dr. Musiek was alluding to, the purpose of the treatment is to improve your quality of life related to the disease and not impair your quality of life due to treatment. And so in patients who have very little disease that, doesn't affect their day-to-day lives, we try to pick as simple as treatment as possible, and that could include topical steroids. But we have some patients for whom they really aren't bothered by their very little bit of CTCL on their skin, and they choose not to apply topical steroids, even that all the time. And I think that's a choice based on how they feel with regards to their quality of life on and off treatment. When it comes to treatment throughout the body, like medicines throughout the body, whether that be IV medicines or pill medicines, we really try to factor in, again, the quality of life and the burden of disease. There's some situations where we definitely start treatment, in the body when patients have rapidly progressive tumors, lymph nodes that are enlarging, blood counts that are worsening with regards to their cutaneous lymphoma. But then I don't think there's an absolute start or stop for most patients. And it's a little bit of a nuanced decision that the patient has with their doctor based on their other health conditions, as well as how much the lymphoma is affecting their day-to-day lives.
Thank you. Anything to add to that, Dr. Musiek?
I was just going to say that, we consider body surface area in this disease like the size of your hand without your thumb. And I think it's very reasonable if you have less than like 3 to 5% body surface area. Like a lot of our patients may not choose to do anything. Some of them may choose to simply apply topical steroid. And of course, we're monitoring them to ensure that we feel like that's a safe option for them. But then 100% what Dr. Mehta-Shah said, we want to make sure that like the treatment is doable and not worse than the disease itself. So we really do make like an individual decision at what point we want to start doing something more.
Perfect. Great. Thank you. Which treatment responds better to Sezary, lacutamab or mogamulizumab?
So I don't think we know totally the answer to that. The study of lacutamab, which is the TELOMAK study, recently completed and was presented. And for Sezary syndrome, all the patients on the study had to have had mogam before. So there's not been studies comparing like if you got mogam versus you got lacutamab. So I don't think we really know the answer to that. Both of them are quite active agents for people who have a high proportion of blood involvement. And lacutamab is not currently commercially available, but mogamulizumab is.
Great, thank you. I was diagnosed with subcutaneous panniculitis T-cell lymphoma with HLH, which is Hemophagocytic Lymphohistiocytosis, and I haven't heard much about this type of cancer and research about this subtype. Can you explain more about it?
Yeah, I can start, and Dr. Mehta-Shah can talk to the HLH component a little bit, but I would say it is a rare subtype. So it's a subtype of cutaneous T-cell lymphoma, but one of the rarer ones. From a diagnosis perspective, it can often overlap significantly with lupus panniculitis. So sometimes it can be really hard to sort out which is going on in the patients. We've had some success in our hands, even if people are beginning to develop HLH-like symptoms, to treat with medications outside of the realm of traditional chemotherapy. So we've had some success using oral methotrexate, so low-dose oral methotrexate, similar to you would use with someone with rheumatoid arthritis or psoriasis. We've also had some luck treating people with targretin or bexarotene. There are other people that I can let Dr. Mehta-Shah speak to that will require more significant treatment, but there's a lot of data to support trying milder therapy if possible initially.
Yeah, I think, as Dr. Musiek said, this is a pretty rare subtype of cutaneous lymphoma. There aren't a lot of studies about subcutaneous panniculitis like T-cell lymphoma in particular. There are studies that have shown that using low-dose oral therapies such as bexarotene or oral methotrexate can be quite effective. I think for HLH is a process where the cancer is causing the inflammation system in the body to become on a hyperactive mode, and then your own immune cells start gobbling up your own cells in your bone marrow, causing fevers and low blood counts like anemia or low or make you prone to bleeding. And in those situations, traditionally in medical oncology, we consider chemotherapy and even a bone marrow transplant. And so I think there are a lot of centers that do pursue that. And I think the extent of this HLH and the concern for how serious it's acting in an individual patient helps to articulate what the best treatment is at that time. But there are not studies of HLH and subcutaneous panniculitis like T-cell lymphoma. There are some studies ongoing looking at drugs specifically for HLH without any regards to trying to treat the lymphoma at the same time. And but those studies have been challenging to do.
Okay, thank you both. It's a very complex issue. I would like to better understand gamma delta CTCL. What are some newer treatment developments to deal with this disease? How successful is stem cell transplant or transfer for gamma delta CTCL in middle-aged individuals?
I can take that one. So primary cutaneous gamma delta T-cell lymphoma is different from mycosis fungoides expressing the gamma or delta protein. So that's a common area of confusion. But patients who have truly primary cutaneous gamma delta T-cell lymphomas usually present with tumors on the body, ulcers, fevers. They often are feeling quite sick, and they notice that these occur often very rapidly. So in that disease, which is very, very rare, I would say even more rare than subcutaneous panniculitis like T-cell lymphoma, there aren't studies of exactly what's the best treatment. There are some studies ongoing looking at inhibiting the macrophage system that are currently accruing patients that are specifically looking at that type of process, not specific to gamma delta T-cell lymphoma, but looking overall at what we call the cytotoxic T-cell lymphomas, of which gamma delta T-cell lymphoma falls into that basket. But there aren't specifically studies looking specifically at mechanisms of this subtype. A lot of the work has been done to try to understand why this subtype originates, where it comes from, how to better understand the diagnosis and the genetic mutational landscape.
Thank you. Had some questions on the rare variants for sure. I have essential thrombocytosis, or ET, diagnosed 17 years ago which may have recently morphed into polycythemia vera. I received my diagnosis of MF in February of this year. I am in the very initial part of my treatment. Steroid ointment, who is the lead medical professional do I look to for my treatment? A dermatologist or a hematologist?
So I think that this is one of these times where either having someone that's like an oncologist who is potentially has experience treating both is an option. But I also think as a dermatologist, we could work closely with your hematologist on this. There are medicines that we could potentially optimize to treat both. I think there's potentially options where we let the hematologist focus on the polycythemia vera and we can safely add treatment to the mycosis fungoides on top of it. I think this would be a situation where two doctors could work together very well. If you're lucky enough to have someone like Dr. Mehta-Shah where you are, then one person may be able to take care of both.
Do you have
I was
something
going
to
to
add?
add that there are some places, and the Cutaneous Lymphoma Foundation can kind of guide you towards those places that have what we call interdisciplinary clinics or interdisciplinary programs where they have an established program where medical oncologists and dermatologists work together, sometimes seeing patients at the same time, sometimes seeing patients like in tandem. But those centers certainly would have some expertise in guiding that decision making as well.
Great. So there's a couple options for people who need to deal with this complicated situation. Thank you. Okay. I have lymphomatoid papulosis, or LYP, also Hodgkin's and mycosis fungoides. Are these all stemming from the same underlying issue? Now, that's a loaded question, too. Who would like to take this?
I can try to start. Dr. Musiek can also chime in. So I think the answer is I'm not sure if they're from the same. There's certainly a proportion of patients who have lymphomatoid papulosis, which is a disease where you develop papules on the skin that under the microscope can look like skin lymphoma, but they go away on their own. And so they were moved out of the category of cancer. But under the microscope, they can look like cancer. And a portion of those patients also have mycosis fungoides. So we think that those are probably what we call clonally related. Like they probably came from the same cell and they kind of broke off and started to develop differently in different parts of the body or at different times, but probably come from the same underlying process. The Hodgkin lymphoma is a little bit complicated because Hodgkin lymphoma can have some of the same markers on the cell surface as lymphomatoid papulosis and associated disorders. And so there are patients who have Hodgkin's and have lymphomatoid papulosis or related disease called anaplastic large cell lymphoma. And those can be very challenging to tease apart under the microscope. And so I would certainly ask your doctor because they probably have a better understanding of your time course of treatment and how these diseases have related to each other to answer that question. So the answer is maybe.
Anything to add?
I was just gonna add that I think this is a really good time for like your clinicians and your pathologist to work together to try to sort of sort out the relationship between what's going on.
Right. Great point. Thank you. Thank you both. Okay. I was reading about new treatments such as Lymphir. What are some new treatments you're excited about? Okay. Either one of you could take this or both.
Yeah, I think like we were alluding to a little bit before, I think some of the newer treatments that are available for treatment in the body include things like antibody-based treatments, such as drugs like lacutamab, building upon antibody-based treatment by adding antibodies that can deliver chemotherapy to cancer cells, of which there are some approved like brentuximab, but there are more in development, using bispecific antibodies, so using allowing your immune system to help treat the lymphoma by kind of showing using antibodies that one part flags the lymphoma cells and the other other part, like kind of brings the immune system closer to the lymphoma cells to treat the lymphoma, are very exciting, as are some of the cellular therapy options and certain more novel targeted treatments that have been already approved or being developed for other cancers or other lymphomas are now being studied in cutaneous lymphomas, like EZH2 inhibitors, are amongst some of the exciting in the body treatments. There are also some developments, I would say, in the skin-directed therapy part that Dr. Musiek can speak to.
Yeah, so there's some studies going on that look at chemicals that photosensitize the skin to visible light, and then the skin can be treated with visible light to hopefully then resolve the patches. They're also looking to leverage maybe some of the medicines we use systemically to see if those can be formed in topical agents and maybe give ourselves more topical treatment options for patients that need that route also.
Great. That all sounds very exciting. At what time frame do you begin to see bexarotene oral capsules work in follicular MF? Does bexarotene permanently damage cholesterol and thyroid levels? What other major side effects have you noticed with bexarotene capsules?
Yes. So follicular trophic mycosis fungoides can be a little more treatment resistant than some of the variants that don't surround hair follicles. So when we talk about follicular trophic mycosis fungoides, we're seeing those abnormal lymphocytes sort of go around the hair follicles in the skin. Typically, I would want to give bexarotene 3 to 4 months to see the full effect. That's assuming that the disease is either staying stable or responding. So if you were taking the medicine and your disease was progressing at a rate that your skin was beginning to feel uncomfortable, then certainly we wouldn't wait that long to see the effect. The effects on both the thyroid and the cholesterol are reversible once the medication is stopped. So almost 100% of people will have their triglycerides increase when they take the medicine, and they will have their brain not tell their thyroid that it needs to make thyroid hormone. So almost 100% of our patients that receive bexarotene are on some sort of cholesterol medication and some sort of thyroid medication, but those side effects are reversible upon stopping. And in our hands, bexarotene can be given safely for years, even decades, if it's working for the patient.
Perfect. Thank you. Okay, next one. So this is a common concern for patients. Do you support the use of alternative medicines, such as the use of herbs and acupuncture treatments? Are they effective? Are there some alternative medicine treatments that you would advise against using? Dr. Mehta-Shah,
I can start. So there's not any known alternative medicines that are approved or have been studied widely in cutaneous lymphomas. So I don't think that I know of one working better than the other specifically for this disease. I think we're not opposed to people using supplements or using acupuncture or other holistic approaches to cancer treatment. But I would say that if you're on treatment through the body, like pills or IV chemotherapy or other IV anti-cancer treatments, then you want to be really open and upfront with your doctors about what you're taking, because there are some medicines that do interact with other alternative supplements. And you want to be aware of whether you could be doing yourself undue harm or making the other treatment not work as well as a result of taking some alternative treatment strategies or supplements. I often refer patients to a site on the Memorial Sloan Kettering website called About Herbs, which is like collates information about alternative treatment, has sections specifically for doctors and for patients about kind of what are the risks and known benefits of some of these alternative supplements. So I think that's a very well vetted resource that is really useful for patients and for doctors.
It's a
And
great
I think
tip.
that if patients, oh, thank you.
Go ahead.
Yeah, I was going to say, I think if patients are wondering, like, well, what else can I do? I think one of the most important things they could do is sort of like take care of their overall health, like be up to date on health maintenance, be as close to possible as their ideal body weight, so that if complications or the need for more intense therapy arises, they're sort of in their best health when they're entering those sort of treatments.
Great, thank you. Is there a risk of infection with duvelisib medication?
So duvelisib is an oral pill that's in the family of PI3 kinase inhibitors. It's been approved previously for a B-cell lymphoma leukemia called CLL, and also for a disease called follicular lymphoma, which is a B-cell non-Hodgkin lymphoma. In those studies, as those patients took duvelisib indefinitely, there's a known risk of infection, specifically viral infections, like a virus called CMV, which is kind of like the monovirus, but not exactly, can be reactivated with duvelisib. But also there's a risk of respiratory illnesses. And on those initial studies, there were more deaths from infection from patients who took duvelisib. Those patients also have often seen more chemotherapy than some of our T-cell lymphoma patients have, and they're often taking it for significantly longer. So the risks, when we've looked at studies in T-cell lymphoma, have not been as clear or as high as it has been with the B-cell lymphomas. So I think, but yes, these are agents that do have risks of infection. Many systemic agents for T-cell lymphoma have some risk of infection as well.
Great, good points. Okay, next question. Do the USA and the UK share information and treatment methods? Dr. Musiek?
Yeah, absolutely. So I was going to say the world of doctors that are interested in committing to treating cutaneous T-cell lymphoma is a relatively small world. So we definitely share treatment ideas, treatment studies, sort of even like classification algorithms with doctors from around the world, and specifically the UK also. Sometimes our medications are approved differently, so we may have access to slightly different treatments just because our regulatory agencies are different. But absolutely, and I will say, as a community, we get together about every year to every other year to specifically talk about treatments as a group.
Right. I know there was just the European Organization for Research and Treatment of Cancer that had people from around the world. Dr. Mehta-Shah, anything to add to that?
No, I think there is a lot of collaboration. I think as Dr. Musiek was alluding to, the process of drug approval is a bit different in the UK across other European countries than it is in the United States. And so there are differences in what's approved, but the studies that are done to lead to approval are usually also done internationally because of the rarity of this disease and the desire for people to work together.
Thanks. Okay, I need to decide on a treatment option, Valchlor versus narrowband UVB. I also have essential thrombocytosis and currently take hydroxyurea. So if choosing the light treatment, I will need to work with my hematologist to find an alternate medication for my ET. What should I be considering to aid in this decision? Thank you.
Yeah, typically when we're talking about skin-directed therapies of, Valchlor, methchlorothamine, or nitrogen mustard on one hand, or narrowband UVB or phototherapy on the other hand, we do sort of exactly what you said. We make decisions based on the patient. So how close does the patient live to a light facility? Is it an option for them to come in and get light treatment? Are they on medicines like hydroxyurea that are photosensitizing that, again, I think could be handled in phototherapy, but maybe make starting or trying topical Valchlor first make more sense? So I think there's no right or wrong answer in choosing which one. It's just a series of decisions based on what fits best for your overall medical history and your overall lifestyle. Again, I think if we are talking about adding phototherapy to a patient that's on a photosensitizing med, it's not an absolute no. We would just have to do it very carefully and think about, can we start at a low dose and increase very slowly in order to do that? Because not everyone will have a photosensitive reaction to a medicine that's known to trigger that. But I think we sort of try to make a holistic decision. What's the best treatment for the patient based on sort of social factors, and medical factors.
I was just going to add to that also that it doesn't have to be like a finite decision. In this disease, we often are trying one thing, seeing how it works for the patient, and being prepared to pivot based on the patient experiences, how their disease is responding, other changes in their healthcare status. So you can try one thing. You don't have to feel the pressure that if you try one thing, it's a forever thing. You can try one thing, and if it's working for you, great. And if it's not, be prepared to switch.
Perfect. Great points. Okay. What are the COVID implications for this season? As we know, COVID and flu season is ramping up, such as getting the COVID vaccine or using the antivirals. Will it flare up disease? Will it make things worse? Or what's the current recommendations? Dr. Musiek?
For patients who are on skin-directed therapy alone, we think that you could consider yourself to be a person who's not immunocompromised when you have cutaneous T-cell lymphoma or primary cutaneous B-cell lymphomas, and so you should make whatever decision you feel like is best for you. With that said, the COVID vaccine seemed to reduce hospitalizations for COVID, and that's really and decrease transmission of COVID. So that's really the reason that people will get vaccinated. For patients who are on treatment for their lymphoma, they may be at times more immunocompromised than the average patient. We don't think that when the COVID vaccines first came out, there were a lot of studies to look at does being on other treatment throughout the body for your cancer impair your ability to mount a good immune response for the COVID vaccine? Or is it less likely to work in you or more likely to work in you than other people? And it seems like the vaccines work just fine in patients who are getting treatment for T-cell lymphomas. The treatment doesn't impair the vaccine response. Getting the COVID vaccine probably will reduce your risk of ending up in the hospital with COVID. And when you're on other cancer therapy, you are already at higher risk of ending up in the hospital for COVID. So we do suggest or endorse patients getting vaccinated, especially if they're on treatment throughout the body. But again, we leave that to the patient's choice as well.
And I would say, if you're worried about your skin flaring after the vaccine, we don't have a lot of studies on this in cutaneous T-cell lymphoma, but we know from our patients that have autoimmune disease, while a few patients flared after getting the vaccine, it was very, very rare. So I'm not worried that after you get the vaccine, your skin rash is suddenly going to be a lot worse than it was before the vaccine.
Great. All right. Thank you. In MF, are there common antigens that the malignant clonal T cells are responding to? It's a great question.
Do you want to take this one?
I was going to let you go ahead. I mean, go ahead and start, and I'll add in when we.
So there are some pretty good studies that have gone on for a few decades showing that when patients have mycosis fungoides and have a super infection with things like Staph aureus or the staph infections, that those specifically seem to cause the inflammatory, what we call cytokines, to be increased, and that seems to rev up the cutaneous T-cell lymphoma as well. And so there are some studies even showing that antibiotics can temporarily improve people's burden of skin disease who have cutaneous T-cell lymphoma, even without using cancer agents that might be treating the cancer. And I think with that data that started about 2 decades ago, many of us are more quick to put patients on prophylactic antibiotics or to treat infections, because we do see that there are times where treating the infection certainly improves the lymphoma or the burden of the lymphoma. And certainly if people have an infection, their lymphoma does flare. There are other antigens being studied in cutaneous lymphoma as well. Those are mostly in the preclinical world. And then there are other proteins that are on the cancer cell surface that are being studied as potential therapeutic targets, but again, mostly in the preclinical world, in the laboratory and mice and petri dishes and stuff.
And That was what I was thinking was with our patients that tend to have super infections in their skin. So that's sort of why we ask, clean the skin, but use mild soap with soap and water. And that's why we're always asking you if you're applying your topicals. We're trying to keep that skin barrier as healthy as possible to prevent infections that may cause flares.
Great, thank you. I have LYP or lymphomatoid papulosis, MF, and currently undergoing treatment on one node for Hodgkin's lymphoma. So first question, are there risks of Hodgkin's lymphoma returning again with the underlying LYP and MF? MF is new and treatment will commence post-Hodgkin's treatment. Plaques and patches are on 30% of the legs. Treatment unknown at this point. And can stress increase occurrences? So two kind of related but different. Yeah.
Yeah. So I'll start with the first part of the question. It's, I think you're in a complicated situation. And as I was alluding to before, there are times where we think these processes could be somewhat related. It's also completely possible that you have LYP and MF, which may be related, and Hodgkin lymphoma, which may be separate. And again, talking to your oncologist and then having a really good understanding of the pathology would be really important. And that communication can happen with the pathologist or the doctors who look under the microscope. There are treatments that we use for Hodgkin's that also do treat cutaneous T-cell lymphoma. Some of the chemotherapies used for Hodgkin's have efficacy in cutaneous T-cell lymphoma. Some of the things that we add to traditional chemotherapy, whether it be brentuximab vedotin, which is an antibody tagged to chemotherapy, or immunotherapy, like things like nivolumab or pembrolizumab, also independently have activity in cutaneous T-cell lymphoma. So it is possible that patients who are getting treatment for Hodgkin lymphoma with chemotherapy medicines or IV medicines may also respond in the skin. And the decision to start treatment for the mycosis fungoides might be dependent on how your skin does after you're done with your Hodgkin's treatment. But it is quite a bit complicated. There's no known relationship of stress specifically causing flares in skin lymphoma or flares of lymphoma. Some of that is being explored through a consortium we're part of called the Lymphoma Epidemiology and Outcomes Consortium, which is like, not looking at physical stress, but looking at emotional stress and burden of cancer across the country. So maybe there are going to be ways of trying to figure that out, but there's no known association at this time.
Great, thank you. So, are there any effective treatments besides rituximab for a B-cell lymphoma?
Yeah, I can go ahead and start this. So there's, a few different types of B-cell lymphoma that we see in the skin, and some require very minimal treatment. So there are some patients that we see with B-cell lymphoma that may choose not to do anything. There are some that may choose to apply topical steroids, and there's some where we may inject steroids under the skin. Other patients may choose to have a little bit of local radiation to areas that are bothersome too. Typically for the more indolent, meaning the B-cell lymphomas that we generally consider not a threat to your overall health, we reserve something like rituximab for patients that have it in very cosmetically sensitive areas or widespread that we would need to clear. Now, there are other types of B-cell lymphomas that happen in the skin that may need more sort of systemic chemotherapy, and I can let Dr. Mehta-Shah talk on that briefly.
Yeah, so as Dr. Musiek was alluding to, in primary cutaneous B-cell lymphomas, we really don't reach for treatments throughout the body very, very frequently, but there are situations that we do. We know that these diseases often will have the spots come back, and so we try not to overburden people with treatment throughout the body. But we do have patients for whom they first have areas on the body and then later develop areas have areas on the skin and later develop areas on the body, or when we find areas in the body. And there's many treatments for B-cell lymphomas in the body. Those include, again, chemotherapy medicines, targeted pill medicines, immunotherapy medicines like bispecific antibodies, which are all approved for B-cell lymphomas. And so sometimes we'll borrow from those as well. But I think having that careful discussion with your doctor is important, because the goal of the treatment for many of these primary cutaneous B-cell lymphomas, like ones that just show up on the skin, is not to make every spot go away 100%. It's to keep them under control and treat it like a chronic skin condition and not something like a dangerous cancer. So you don't need to make every spot go away, because that might give you more side effects over your lifetime that may not make sense for you.
Okay, thank you both. I have a rare form of cutaneous lymphoma, primary cutaneous peripheral T-cell lymphoma, not otherwise specified. I'm 83. I would like to know what research is being done to find treatments for those of us who do not qualify for transplants. Dr. Mehta-Shah?
Yeah, I can take that. So primary cutaneous peripheral T-cell lymphoma is a clinical manifestation of patients who have peripheral T-cell lymphoma. It's very hard pathologically to distinguish that from a single spot of transformed mycosis fungoides. And so sometimes there's a lot of debate about what the disease really is and what it represents. And so I think most of the research in this area is really trying to figure out like which one is which and which one is likely to cause danger in the body and which one is going to be a skin tumor that was self-limited and does not need as much treatment. And some of that work is being done by looking at like the genomics of those diseases to identify ways of looking for disease in the body, in the blood, called minimal residual disease techniques, like looking for the DNA of the cancer cells in the body to help distinguish that. I would say there's lots of treatments being explored for peripheral T-cell lymphomas for patients who are not candidates for transplant. Some of these are, again, same themes, bispecific antibodies, oral therapies that might be targeted, other chemotherapeutic approaches, combining those approaches, CAR T cells, but I would say it's not right now, I would say specific to this very uncommon presentation.
Thank you. Very complex issue once again. Okay, next question. In MF, what is causing the itching in places where there is no plaques, patches, or redness? Dr. Musiek.
Yeah, so we know that sometimes people itch even when they don't have lymphoma and they have no rash. We still think this is an interplay between like our immune system and the nerves at the periphery. So in our patients that itch, but they don't have rash in the specific areas where they itch, we would still probably increase our therapy for the lymphoma first to see if we can improve the itch that way. If we do that and their skin is so clear, their blood is so clear, their lymph nodes are so clear that it doesn't make sense to add more therapy because we don't want to increase that toxicity, in those situations, then we would sort of go back to target the itch itself. But we think the itch we're feeling is an interplay between our nerves and our immune system.
Thank you. Such a mystery for patients, right? And frustration for them. Yeah. Well, this is related. Is there anything to help with the itching? Topicals or oral medications?
Yeah, absolutely. Like I just said, like our goal would be to sort of get the underlying lymphoma under the best control as possible first to see if that helps the itch. If not, there's certainly topical things we could try, including topical steroids, counter irritants, like we recommend Sarna a lot, as the menthol and camphor can cool the skin. Sometimes even things like icy hot fans, anything that sort of feels cool when it touches the skin can be helpful. We do sometimes like leverage other medications that can be helpful for itch. So sometimes we use pill medicines that can help with the itch. Sometimes we use some of the antidepressants that can also help with itch. So we are trying, if treating the lymphoma isn't enough, we are trying other strategies with medicines that more directly target itch than target the lymphoma itself.
Thank you. So things in the toolbox to help with this. How will I know if mycosis fungoides goes beyond my skin? Dr. Mehta-Shah, do you want to?
I can take that. Yeah. So inpatient, as Dr. Musiek talked about earlier, only about 15% of patients will ever have their disease progress from their initial stage, meaning like what you start off with in terms of how it appears on your body, probably going to be how your lymphoma is going to act. For patients who do progress to having it in the lymph nodes or in the bloodstream, there are ways that we use to check for that. But it is also very unlikely that that is going to happen where it grows in other parts of the body when it is not changing on the skin. So oftentimes what prompts myself or Dr. Musiek to look for areas in the body is often when we see changes in the way it's acting in the skin, or it's not responding to treatment in the way that it usually would. And those are reasons that we might start looking. The modalities that we use to look or to examine the patient, feel for lymph nodes, look for tumors and such. But then we'll also do sometimes, if we're worried about disease in the lymph nodes or other areas in the body, we'll do a CAT scan or a PET scan. Similarly, to look for areas in the blood, we'll check their patient's blood count, look for the number of lymph cells, and sometimes do specialized tests to count the number of abnormal lymph cells in the blood. That can be done through a blood test called flow cytometry.
Great. Anything to add, Dr. Musiek?
No, I don't think so. Thank you.
Okay, great. Thanks. I developed pancreatitis after being on bexarotene for about 6 years. Do you think the bexarotene is the cause of the pancreatitis? And what is a good alternative to bexarotene? Dr. Musiek, would you like to?
Yeah, absolutely. So, we talked about bexarotene increasing the triglyceride levels, and we've seen patients' triglyceride levels go very, very high, in the range where we worry about them developing pancreatitis if we don't get the levels down quickly. So it's hard to know, in your situation, because there's lots of other causes of pancreatitis also, if the bexarotene caused the pancreatitis or not. But certainly in the setting of bexarotene causing elevated triglycerides, we can see that. I think alternatives for bexarotene would largely depend on what your disease looked like in the moment. So there are other medicines that are similar to bexarotene that are retinoids, not rexnoids, the way bexarotenes are, that may increase the triglycerides less. And then we could switch treatment altogether if it seemed like bexarotene was no longer a good option. So a little bit would depend on the stage of the disease and how active the disease was currently.
Great. Thanks, Dr. Musiek. So everyone, we are about 5 minutes away from being at our close. So I'd like to get to a few last questions. We're going to call this our speed round. So let's see what we can do with it. What's the difference from CTCL and cutaneous panniculitis T-cell lymphoma?
So cutaneous T-cell lymphoma is an overall classification for many different types of lymphomas that happen in the skin. And panniculitic T-cell lymphoma would be a subheading under the heading of cutaneous T-cell lymphoma.
Okay, thank you. Are there any data on how successfully stem cell transfer is for cutaneous panniculitis T-cell lymphoma? Dr. Mehta-Shah.
Yeah, there's not great data for that because the stem cell transplants are not used for all patients with subcutaneous panniculitis like T-cell lymphoma uniformly, and they're often used for high-risk individuals. So I would say there's not great data specifically for that subtype on the outcomes for stem cell transplant. Most of the series have been quite small. I apologize for the darkness in my room.
We can still see you.
Yeah.
Thank you. Why is it so difficult to diagnose cutaneous lymphoma? That's a loaded question too.
It is a loaded question. I think we're getting better. It's difficult to diagnose because if you're the kind of person that is red all over, once you're red all over, no matter what you have, if you have psoriasis, eczema, cutaneous T-cell lymphoma, the biopsies all look very similar under the microscope. If you have early stage disease, it's hard to make the diagnosis because there just aren't many lymphoma cells in the biopsy specimen for our pathologist to look at. So while I think definitely we're making it faster than we used to, it's still really hard to get a piece of skin under the microscope that 100% makes the diagnosis. That's why we need to use the clinical pathologic correlation and look at both what we see under the microscope, but also look at what we see in the skin and see if we can put those things, and potentially what we see in the blood, to see if we can put those things together and come up with a diagnosis, sort of using all the pieces of information that we have.
Great. Yeah, it's such a dilemma for patients when they struggling with a diagnosis. Okay. Is following an anti-inflammatory diet advised, recommended for those of us with CTCL? Does diet have anything to do with flares? Dr.
There's not
Mehta-Shah.
a known role for anti-inflammatory diets in lymphoma and specifically also in cutaneous T-cell lymphomas as of yet. There's some studies that have looked at things like fibromyalgia and other pain disorders in anti-inflammatory diets improving outcomes. I tell patients that if they feel like if they would like to pursue an anti-inflammatory diet, we're not opposed to it. We don't think it hurts you either. And it's about doing what you feel like is healthy for your body, but it's not known to help.
Great, thank you. Well, unfortunately, we have time for one more question, so here it is. How long does it usually take treatment to clear the skin completely of follicular mycosis T-cell lymphoma plaques? I have been under treatment for almost 16 months. Dr. Musiek?
Yeah, so I think, again, the goal may not be to become 100% clear. The goal may be to become clear to the point where you feel comfortable with how your skin looks and how your skin feels, and for your doctors to feel like the skin lymphoma isn't behaving in a dangerous way. So I can say that I have patients that I've treated for decades that aren't 100% clear, but they're clear enough that they're happy with the day-to-day life. So I think that if after 16 months on a set therapy, you're not happy with how the skin looks and feels, then it may be time to add something to that treatment or potentially talk to your doctor about changing treatment. But I think the reality is that 100% clear may not be the goal. And so you need to decide like sort of what your threshold is, how you feel about how your skin looks and how it feels to know what is the right step as far as changing or escalating therapy.
Great. Thank you. Well, I want to thank both of you for taking time out of, I know, what is very busy schedules for you to answer these questions from our community and for sharing your knowledge and expertise. It's invaluable. Before we leave, I wanted to ask both of you if you have any parting thoughts. Dr. Musiek?
Yeah, so I think, again, what we sort of talked about is a lot of times these treatments aren't a yes or a no. They're discussion with the doctor about what is best for you. And I think that if you have questions, we feel really confident in the literature that's vested by the Cutaneous Lymphoma Foundation for patients to look to if they need more information.
Thank you, Dr. Shah. Mehta-Shah.
Yeah, and I think the Cutaneous Lymphoma Foundation does really terrific work with being able to connect you with experts if you wanted to get a second opinion, but then also connect patients with each other because I think the experience of cutaneous lymphoma patients is quite unique compared to many other cancers. And there's a lot to learn from each other and to have that open dialogue with your doctors, because I think in this disease in particular, it's very much shared decision-making that's important.
Perfect. Thank you so much. And thanks again to both of you and to everybody who's attended this program for submitting your great questions. We had some good ones in there. We hope it was helpful. My last ask is that you complete the survey, as it is very helpful to us in bringing these programs to you. And have a good rest of your day, everyone. And goodbye for now.